Hello, and welcome to the first Springboard Journal Club. My name is Jessie, and I will be presenting on behalf of my co-authors, Ariana Serino, Alice Payne Merritt, Gabrielle Hunter, Martha Silva, Priya Parikh, and Paul Hewitt. The article we will be discussing during this Springboard for SBC Journal Club is titled Evidence-Based Process for Prioritizing Positive Behaviors for Promotion, Zika Prevention in Latin America and the Caribbean and Applicability to Future Health Emergency Responses. The article was published in Global Health, Science and Practice in September of 2019. This presentation will give a quick overview of the content that you will find in this article, and we look forward to discussing it over the next 2 days. When Zika cases were first detected in Latin America, evidence was still emerging about the disease. For example, that it was being transmitted sexually, a mode of transmission not previously reported for Zika, and that it was linked to a range of congenital delays in babies born to mothers infected with Zika during pregnancy. Organizations working in the field began to implement programming for behavior change as evidence continued to evolve. At the close of the first year of programming, through a rapid review of implementing partner materials, we counted over 30 variations of Zika preventive behaviors being promoted across the response. Best practices from behavioral science, social marketing, human-centered design, and other areas of research have shown that promoting well-defined messages around a short list of behaviors clearly, consistently, with specificity and repeated often through different channels improves behavioral uptake and leads to greater recall of messages. To have an effective program, then, we know that we need to harmonize across partners and speak with one voice, but that was not the case 1 year into the Zika response. To solve this problem, we developed and implemented a prioritization process to aid in the planning of any SBC program and future outbreaks such as Zika. Our process was flexible and followed these 8 steps. First, we identified stakeholders. This step was led by the prioritization team, USAID, Breakthrough Action, and Breakthrough Research. Stakeholders included members of the USAID Zika SBC Working Group, comprised of implementing partners and a diverse range of technical experts in the field responding to Zika. Next, we established our objective, to identify a short list of behaviors with the highest potential to prevent Zika transmission and negative pregnancy outcomes based on existing evidence and implementation experience, targeting our priority audiences, pregnant women, their partners, and those who influence them. Of the over 30 variations of behaviors, we grouped together similar ones, reduced according to any limitations or known ineffective behaviors, leaving us with 13 candidate behaviors. Next, we needed to decide what criteria to use to assess these candidate behaviors. This is a table displaying our final prioritization criteria. These were determined based on a consensus-building approach led by Breakthrough Action. We decided on 2 criteria gleaned from available evidence to determine how effective behaviors were for reducing Zika transmission and negative pregnancy outcomes based on published papers and reports and at what scale. The third criteria, amenable to change, was based on 3 subcomponents to determine how likely the behavior was to be put into practice. These components were: how frequently do you need to carry out the behavior for it to be effective? Is it feasible for someone to carry out this behavior? Meaning, how complex is it? Could you do it alone, or did it require negotiation, for example, condom use? And third, is it easy to access any required materials for the behavior? So if we are going to ask people to scrub their water storage containers with bleach, we need to know if this is too costly and how available bleach may be for families in this context. So now we have the 13 candidate behaviors and we have our criteria for prioritization. And our goal was to reduce the number of behaviors even further. The next step was to conduct an evidence review to determine what was already published or reported regarding prevention of transmission of Zika, then summarize our findings. This is an outline of the literature review process. We identified peer-reviewed papers in Google Scholar published after 2012 but included any seminal works from before 2012. And we also collected additional records identified through gray literature. We included 108 articles on 5 behaviors based on our exclusion criteria. So what were we looking for in our evidence review? We were looking for different types of publications with attention to the level of rigor of the methodology used to determine what behaviors were effective for Zika prevention. However, there was very little published about Zika, especially for Latin America and the Caribbean, because it had never been there before. So we sought to learn from evidence regarding other diseases with similar modes of transmission. Other arboviruses, such as dengue and chikungunya, are transmitted by the same mosquito as Zika. We know there is a lot of evidence regarding Aedes aegypti mosquitoes that we could adapt and learn from. An added challenge, though, was that unlike dengue or chikungunya, Zika is sexually transmitted. We assessed research on other sexually transmitted infections and what works, for example, promoting condom use. But for sexual transmission, there were no perfect parallels for Zika. We adapted information as best we could from other Aedes-borne arboviruses due to the similarities in vector control behaviors, and from the STI/HIV literature around prevention of sexual transmission of diseases. We had to get creative, seeking information in conference proceedings or even phone calls with experts conducting ongoing research so that we could gather the most up-to-date evidence. Other challenges that we faced in the evidence review were that we sometimes found articles that did not provide enough detail on how exactly the behaviors were carried out, and sometimes behaviors were packaged together into an intervention or research study, so it was difficult, if not impossible, to isolate one behavior to see if it was effective or if it had to be part of the larger package of behaviors. So after concluding the evidence review, we summarized the evidence, and each behavior was run through the criteria we developed in step 4. After additional review and consensus building with stakeholders, a final set of 7 behaviors with the greatest potential to reduce negative pregnancy outcomes related to Zika were selected. An important note is that these steps were designed to be flexible to account for situations where we didn't have all of the information or where we had to adapt based on the needs of our partners or the realities on the ground. We started developing this process in November of 2017. We refined the criteria and list of behaviors after seeking feedback at multiple working group meetings. We had the opportunity to contextualize the process and behaviors in a few countries to beta test. And by May 2018, we had reached a consensus and disseminated the results of the prioritization process broadly. So what did we learn through this behavior prioritization process? First, that public health emergency contexts are challenging. There is an urgency when facing a disease outbreak of any sort. This creates shorter windows for design, implementation, coordination, and harmonization of programmatic and research efforts. So why was our process successful? Because this process was widely considered a success within the Zika response. This is because it was an evidence-based, collaborative process, and the result was a more harmonized response while still allowing for contextual adaptation. The recommendation for future public health emergencies is to carry out this prioritization process at the outset, using the most robust evidence available and supplementing with technical expertise from other areas when sufficient evidence is not available. It's also worth mentioning that even if the disease being responded to is well researched, this process is still extremely helpful in designing any SBC response because it helps build consensus and prioritizes behaviors based on evidence. For more information on the Breakthrough Action and Breakthrough Research projects, please visit our website. We have added a second link below where you can find other materials related to the application and lessons learned from the behavior prioritization process during the Zika response. We look forward to your questions and comments over the next 2 days in Journal Club. Thank you.